Hi, I'm Gary Lichtenstein from University of Pennsylvania here in Orlando at the Advances in Inflammatory Bowel Disease course with our symposium we just are going to show you on management of inflammatory bowel disease patients who have iron deficiency. My colleague today with me is Dr. Millie Long from University of North Carolina. Millie?
Hi, Millie Long. I'm professor of medicine at University of North Carolina, and I just had the pleasure of presenting on iron deficiency with Dr. Lichtenstein. And we thought that what we do is highlight some of the important aspects of the program. And so, Gary, the first question I had for you is, why was this program important for you to participate in?
Well, I think education is part of what we do, and our mission in life to educate others what's appropriate to do, specifically relating to the care of patients. And iron deficiency is one of those disorders that we see, but we don't recognize many of the time. So it's really developing and advancing the science, if you would, of caring for patients that have iron deficiency and recognizing who's at risk for this, and then focusing on treatment as well. So that's really primarily what we did and are going to talk about now.
Yes, no, absolutely. There are a number of key pearls from the symposium. And what do you think would be one great teaching point that you'd like our audience to leave with?
Well, I think one of the most important things that we do is treat the patient. And we have to talk to the patient and ask them symptoms they had and how do they feel. And in doing so, we may find that many of our patients have symptoms that we don't recognize. For example, fatigue. Restless leg syndrome is a common presentation in iron deficiency. Cognitive difficulty as well. These are things, some of the many things that we see. Dyspnea on exertion, particularly when climbing stairs, is a common scenario that I see in clinical practice in patients that have iron deficiency that's often unrecognized. But these and many other things to really put together your head and say, what should I ask that patient and how should I attack this with that particular patient? So it's a patient-focused, shared decision-making process that we do.
Well, let me ask you this. What do you hope? I mean, I think that one of the things that it can be difficult is that some of us are pretty far from kind of management of iron deficiency or recognition. What do you think is one thing clinicians can do differently after participating in this program that may help them in their day-to-day practice?
So if a patient has a normal hemoglobin, and we say that anemia in a woman is a hemoglobin less than 12, in a male it's a hemoglobin less than 13, then to think of iron deficiency. And if you think about it, then you can really discuss with the patient what are appropriate ways to treat it and keep them from having symptoms potentially related to this, as well disease complications. So these are things that are important as well. We often think that a patient may be inactive with IBD. For example, calprotectin may be normal. CRP may be normal. The patient may have severe disease. So do endoscopy and look and see. These are things that we should really be focusing on in clinical practice. And they're in the guidelines, if you would. So we have to reinforce what's published in the guidelines and, importantly, tell our patients why we're doing things.
Absolutely. Taking a holistic approach to care, which includes the assessment of their etiologies for their underlying fatigue or other symptoms. You know, in fact, in my practice, I will actually at least once a year check iron studies on my patients, because what I find is that sometimes they're symptomatic, they're fatigued, but they've been dealing with their disease for so long that they may not necessarily recognize it as a difference. But that simple test of kind of checking their iron levels once a year can be incredibly helpful. I like it when I catch the iron deficiency before the anemia part.
And it's interesting to see in clinical practice, many times a patient may have a hemoglobin of 8 and say, my doctor said that's where I am. That's where my disease is. And as a consequence, really being accepting of something that's not really standard of practice, nor is it appropriate for the patient.
Right.
The patients then go back once they're treated and say, wow, I didn't realize how bad it was. So I think using this as a metric, with regards to a quality metric, if you would, for care, this should be an important focus of what we do.
I absolutely agree. I have one final question for you, which is we did this program in conjunction with CME Outfitters. Do you have any feedback for CME Outfitters or working with them to develop this program?
They're fabulous. I think that what they did is allow us to do what we thought was medically appropriate and to put it together. They've been nothing but superb in all aspects, and they've really enabled us to do what we feel is best for education. As a continuing medical education program, this is something that we'd like to look at all participants, whether they be advanced practice providers, physicians, pharmacists, or anyone who wants to learn, to really get the recognition they need from this program.
I completely agree. And one thing that kind of hit me, I've never had so many participants ask for access to the slides, the resources that CME Outfitters makes available. So I think it'll be continued medical education for our participants, hopefully not only here in person in Orlando, but also online viewing the activity.
I agree. This should be a resource that is viewed and recognized to be important because it's often overlooked. And to have nice slides and be able to present yourself on this and educate your practitioners in the community or in the practices you serve in an academic medical center or even patients, this is helpful.